SNN, I saw the warning of your Commissioner Radhakrishnan in Times of India. Did you see that? He says cases are rising, not to go out and all that.
Yeah.
Is it true? Cases are rising in Chennai?
We don't know exactly the number of people who are now getting affected, but it seems to be on the higher side. That's what people say. In private hospitals, there is not much of increase.
I think 1 minute left. Sorry. So are we good to start, madam? Am I audible, Dr. Narasimhan?
Yes, sir. Yes, sir. You are
Yes, sir.
audible,
Yes, sir.
Sir, he has started.
Started? Okay.
Yes.
You can share your slides, Dr. Neeraj.
So we can start now.
Yeah.
And
No,
so over to you, sir. Yeah.
Yeah. Do you have a corporate presentation?
So he was running in the meanwhile.
Okay,
so
it was going on. Okay, no separate one. Okay, okay. Then I'll start my presentation.
Yes, sir.
My dear friends, Madam Rita from HiGlance, the head of country division, Dr. Neeraj Singh, and my dear esteemed colleagues, Dr. Narasimhan and Dr. Parag, who are here to deliver the talks. Dear friends, I personally feel this is a very highly impactful meeting, and we are discussing today are very important aspects of diabetes management. As we are aware, the diabetes is a disease of the lipid metabolism, a disease with a very great association with hypertension, and also it's a disease which has a lot of things to do with its management. And the oral anti-diabetic agents remain at the mainstay, the pillar of diabetes management. Dear friends, I will start off by saying that today, this evening, over the next 1.5 hours, we'll deliver 3 lectures. And the next half an hour, we'll have very interesting panel discussion on the hypertension, obesity, lipids, and diabetes. We have acronym it as the Hold Summit. And we have with us, Ajay introduced you two people who are absolutely the top of the world to discuss the topic. Without taking any further time, may I start my presentation now? I'm going to talk about today on a very interesting topic, atherogenic dyslipidemia in diabetes. What does the guideline say, and what is our clinical practice today? And this presentation is based upon the latest guideline and also on the study that we had carried out to find out the pattern of practice of dyslipidemia management in our country. Dear friends, I have brought in this presentation a small introduction to say that how lipids are very closely associated with diabetes mellitus. It was Jocelyn who said, as you remember, with an excess of fat, diabetes begins. With an excess of fat, diabetes ends. And therefore, dear friends, it is very important to remember that the diabetes is basically a very strong association with lipid disorders. But why are we discussing this topic? We're discussing this topic for four reasons. Number one, in our country, the importance of dyslipidemia is far more important than elsewhere in the world. It has been said that Southeast Asian countries, the atherogenic dyslipidemia is much more than elsewhere in the globe. And I will show you what its impact on the coronary disease. Second point, by we have in the armamentarium wonderful drugs to treat it. And the treatment of this dyslipidemia can bring down coronary disease by at least 33%. But lo and behold, I'll show you the pattern of practice, which was carried out in 2018 and 19. And this reflects the whole country. SNN and Parag will agree with me. And you'll see how callous is the management of dyslipidemia. We have wonderful drugs, but we don't use it. Third important point that why this topic has been chosen for this seminar today is that there have been a lot of advances in the guideline. Now, I will take you through 1980 to 2020, the Lipid Association India guideline. As you will march with me, you will observe the values have been lowered from 130 today to about whatever you say, 100, 70, 55, or even 30, depending upon the risk stratification. I'll take you through that. But the bottom line, the fact of the matter remains with the notion that our people have that lipids are not taken seriously. People say that diabetes is basically sugar disease, they take care of sugar. So I'm going to show you that how this treatment is paramount importance. And finally, my objective today is to give some clear messages. Dear friends, if you read the guideline yourself, you will find there is a lot of conditionality, above 40, below 40, between 40 to 75, 75 and above. I will take away all that. Today we have simplified. I call it KISS. Keep it simple and straight. In the fear of omitting some mechanistic points, omitting some details of points, I will give you the crisp clinical practice points. I call it practice essentials, which you will now. You see, hypertension. Long before, there were so many 140 by 70, if nephropathy 130 by 85, if da. But today we said that across the board, the guideline for hypertension is to maintain 130 by 80. So I'm going to give you some such messages, which from the guideline I have extracted to be the simple message today. So these are the four objectives of my talk today. I hope my dear friends who have joined in large number, for whom this seminar is meant, will enjoy it. I'll go through the epidemiology of dyslipidemia and diabetes. I'll also discuss very, very briefly the pathophysiology. But the emphasis will be that how should we manage? How do we monitor? The management is dependent upon the guideline. I will tell you the guidelines that are available, and the monitoring is available. I'll tell you how do we monitor, 6 monthly or yearly, and should we stop when I have met so many physicians, they say that when the lipids come down, we stop the drug. But once you stop the drug, it can go higher. So we'll discuss all these points, and we'll have a full 30 minutes for panel discussion. Dear friends, what is dyslipidemia? By definition, simple definition, keep it simple and straight. Elevation of plasma cholesterol, triglycerides and LDL, or both low dense lipoprotein and triglyceride, and a low HDL-C. Therefore, dear friends, the triangle of atherogenic dyslipidemia contains low HDL, high triglyceride, and high LDL cholesterol. And this is basically a disorder of the lipid and lipoprotein metabolism. It's of two types. It can be either a familial or it can be secondary. Familial usually genetic disorder, which we will discuss that today, but we have a registry in our country which registers all the familial hypercholesterolemias. It is maintained from the Gangaram Hospital by my friend Dr. Singh, and you know it is a kettle. It's a different kettle. We'll not touch it today. But secondary dyslipidemia, which is most prevalent, 99% prevalent, occurs because of diabetes. We are discussing today. You must also know that we have to take it out for the, it can occur in nephrotic syndrome, differentiate it out. It can occur in hypothyroidism. It can be hypertension. It can be drug induced. It can be drug induced. Now, if you look to the, regions, why does it occur? You will find that why are you worried about dyslipidemia? I'll again make it very clear. Diabetes is a pandemic. We say COVID and diabetic a double pandemic. And an important cardiovascular risk factors. The lipids are an important risk factor. The atherogenic dyslipidemia in diabetes is characterized, as I told you, high serum triglyceride, high small dense LDL. Just remember small dense, I'll explain what it is, and high and low HDL, and postprandial hyperlipemia. What the primary cause of the ADD, atherogenic dyslipidemia? The primary cause is insulin resistance. This cartoon shows that lipid triad, low HDL, elevated triglyceride, elevated small dense LDL are the triad of the atherogenic dyslipidemia. Now, dear friends, we have lot of anti-diabetic drugs, but you see that if you give the metformin, these various types of drugs that we use in diabetes mellitus, and they do have an effect on lowering the lipids, like metformin, triglycerides and LDL cholesterol, pioglitazone, triglycerides and LDL, and it increases the good cholesterol, LDL cholesterol. Roji is no more in the market today. Glibenclamide plus minus for the TG and LDL cholesterol, HDL cholesterol also plus minus, and we have the drugs we have given here which can bring down the lipid minimally. Now this slide is meant to convey the message: if the sugars are very high, you please wait for 1 or 2 weeks till the sugars to settle down, because with the settling down of the hyperglycemia with the anti-diabetic drugs, the lipids may come down considerably. So hyperglycemia has to be brought down. Now, what is the prevalence of the problem we are discussing today? Globally, 3 out of 4 diabetics suffer from dyslipidemia. Now, you have in India, globally 3 out of 4, but in India it is 75%. In India, it is 90%. Shown here, prevalent dyslipidemia in male, 86%. Dyslipidemia in female is 98%. So this is a huge problem in our country. So we're discussing today. Dear friends, what is the Indian scenario? We have the nature, because we are genetically determined dyslipidemia. We have high TG levels, high small dense LDL levels, and LP little a is in excess. But we also have the nurture, our own healthy lifestyle. The entire ICR in-depth study, which I co-chair today along with Dr. Nath, we showed to the world that the greatest malady of dyslipidemia in our country is lack of exercise. Unhealthy lifestyle associated with affluence, urbanization, mechanization is the most important reason for the dyslipidemia. Now, increased to that, we have the South Asian paradox, because we have increased severe risk. It has been shown by many investigators. Now, we have excess burden of CAD among Indians, primarily due to dyslipidemia. Indians have high LDL, low HDL, and high triglyceride, which are perfect, what should I say, perfect batch, perfect formula for getting coronary disease. High LDL, high TG, low HDL. And we have LDL more than 100, which is the minimum target in more than 60% cases, and a TG by HDL ratio, triglyceride HDL ratio, when it's greater than 3.8, it is highly predictive of small dense LDL among the Asian Indians. Many labs cannot do the small dense LDL, but this formula can be applied. Now, patients with LP little a excess, coronary artery disease risk increases not by 1 or 2-fold. LP little a increases coronary disease risk by 12-fold with high LDL. Now, what are the unique features of coronary artery disease in us, and why are we worried about dyslipidemia in our population? My dear colleagues who are attending this seminar, I must tell you that we are 5 times more prone to develop MI and death compared to Caucasians. We have high prevalence of the atherogenic small dense LDL, high prevalence of the lipoprotein little a potent atherogenic lipoprotein. I showed you 12 times more prone. We are prone to develop the coronary disease before 40 years of age, higher incidence of metabolic syndrome and dyslipidemia, and elevated pro-thrombotic and pro-inflammatory factors. Now, this is the study I was referring to. This is called our lead study. We have published this. Now, this shows that we have, in our study, where we looked at the prevalence of Indian dyslipidemia, we found that LDL excess of 100 was in 70%. The study was done in a population of 4,060. We found serum triglyceride more than 150 in again 65%. And almost we said that the patient is studied that almost at least every second patient has some form of dyslipidemia. And dyslipidemia diabetes, Indians are not on goal for the LDL cholesterol. And 9 out of 10 Indians, more than 40 years of age with atherosclerotic cardiovascular disease factors, do not achieve the LDL goal. I'll tell you what is the goal for us today. This lead study called the Learning with Experts to Advance Diabetic Dyslipidemia Management, this paper is also published. It showed that 9 out of 10, we have classified the dyslipidemia to extremely high risk, very high risk, and no categories. High risk, extremely risk patients are those who have already IHD or coronary disease. Very high risk are the diabetes with +1 or 2 more ASCVD risk factors. High risk are diabetics, but they have no other risk factors. This is the extreme risk, very high risk, and the high risk. And we found 9 out of 10 extreme high risk patients are not on LDL target, not LDL target. You see the percentage of patients in the extreme risk who are not on target almost amounted to 90. We have put details here, 94.77%. Now, these people, the target is 55. The latest guideline target 55. I think Dr. Narasimhan, Dr. Parag, who are experts in this, will agree with me. Now, for the very high risk, diabetes, one risk factors, the target is 70. And for the high risk, target is 100 in diabetics. Now, we found that if you take into consideration here, only 11% are on target, 8-10% not on target, and here 46% are only on target, 54 are not on target. Now, the mean LDL levels are given here. Now, the statin dose and the intensity recommended is high intensity atorvastatin, that is 40 to 80, rosuvastatin 20 to 40, and here for high risk, moderately intensive atorvastatin 10 to 20, rosuva 5 to 10. Now, percentage of patients not receiving the recommended dose, you see the high percentage who do not get the recommended, even in the ordinary diabetics, the 90% do not get the recommended dose. So therefore, we said 9 of 10 high risk patients are not on LDL target, 5 of 10 high risk patients not on LDL target. And if you look at the dose they're receiving, you know, people start for very severe dyslipidemia 2.5, no harm in starting, but you have to escalate it, you have to optimize it. So 8 out of 10 extremely high risk patients do not receive the recommended dose of statin. 9 of 10 very high risk patients do not receive recommended dose, and 1 out of 10 high risk patients do not receive the recommended statin dose. Dear friends, I have shown the targets here. Now, coming to the risk stratification and risk-based LDL lowering therapy, according to ADA 2018 recommendation, And the previous one I showed was ACE recommendation, ACE 2017. This year when we started this study. Then in 2018, the AD recommendations came. I'll be very brief to say that the recommendations by this below 40 years of age, people are not on target, LDL target, are about 67%, with ASCVD risk factors 65%, and without risk factor only ASCVD is about 80%. That means majority of the patients not on the target below 40 years of age. But that is something. But above 40 years of age, usually the percentage of people who are not on the target. Therefore, more than 75% of the patients above 40 years of age, which are common type 2 diabetic population with ASCVD or ASCVD risk factors, are not treated with high intense statins. I'll repeat again, more than 75% patients more than 40 years, equal to 40 years of age with ASCVD or ASCVD risk factors are not treated with high intensity statin, almost 3/4 of the patients. And I have highlighted the various factors responsible for that. Now, is dyslipidemia prevalent very highly in our country? Answer is yes. This is from the ICOR in-depth study. We have found the prevalence of diabetes 11%, pre-diabetes, diabetes at least 7 to 9%, urban, rural given here. But look at the various other factors. We found the dyslipidemia is very, very high. This study by Rakesh Parikh and Shashank Joshi from Bombay, Padma Menon from the KMC, and Nalini Shah again from the KEM hospital. You find the dyslipidemia diabetes almost 97.8%. And you see mixed dyslipidemia is about 40%. Now, so majority of the Indian type 2 diabetic have dyslipidemia. Now, so this is a study by Amrish Mittal from the Medanta Hospital, now in Max Hospital. And you will find that in this study, he found only less than 50%, 49% to be exact, who were on statin therapy had their LDL cholesterol within target levels. So look at this. That it is a paper 2014. That time the target was even higher, but less than 50% were on the target. Now we have the greater risk of this dyslipidemia producing narrowing of the coronary arteries. We have more of coronary artery disease incidence and mortality. It is twofold higher amongst Indians. Now, what are the risk factors for the atherogenic dyslipidemia? So this I will bring to you because you must control risk factors. Major advancing age, we cannot do anything about it. We cannot remain at the constant age. But there is major risk factor. Total cholesterol high, non-HDL cholesterol high, LDL cholesterol high, low HDL cholesterol. This is the usual atherogenic dyslipidemia. The important cause is diabetes, hypertension, chronic kidney disease, cigarette smoking, and family history of ASCVD. Dear friends, if you have a patient with this type of constellation, be severe in the treatment. What the additional risk factors? Obesity, visceral obesity, family history of dyslipidemia, and the patient who has small dense LDL high, ApoB high, LDL particle concentration high, and those who have PCOS. Now, those who have lipoprotein high, clotting factor high, inflammatory markers high like HSCRP, who have homocysteine level high, and those who are uric acid high and triglyceride rich remnants high, they are the people who are non-traditional risk factors for the atherogenic dyslipidemia and diabetes. To make a long story short, diabetes, hypertension, obesity, chronic kidney disease, cigarette smoking, family history of diabetes or hyperlipidemia, and the persons who are with visceral obesity are the ones who develop dyslipidemia. Dear friends, I will not go into details of the pathophysiology, but this is a very interesting slide to say that the environment, like lifestyle, medical conditions, pregnancy, and medications, the genetic common variants, rare variants are there. We can't do anything about it. We cannot choose our parent. Genetics out of question. We cannot even choose our in-laws. Maybe some younger audience people can choose their in-laws. So this environment is dependent upon the production and the clearance. So TRL stands for the triglyceride rich pool, and HD high triglyceride, and you find the various things that we have given here. Triglyceride rich lipoproteins. We have the high triglyceride group, we have the high RLP group, PPHL group, high small dense LDL group, low HDL cholesterol group. Now this constitutes the atherogenic dyslipidemia complex, and this is the one which is responsible for the atherosclerotic cardiovascular disease. Dear friends, I have told you what gives. In the last 15 minutes left to me, I'll just talk about the guidelines. As I told you, I'll be very, very simple. Now you see that this is the guideline from the American. We have got the American Heart Association criteria, American College of Cardiology criteria, and you will find the criterias are very simple, and the criteria clearly outline what should be done. How do you secondarily prevent clinical atherosclerotic cardiovascular disease? Give healthy lifestyle, which cannot be dispensed with. Number one, number two, number three. Those who are at very high risk, I have told you who are at very high risk, those who already have a CAD, already have a coronary bypass, whatever, we need high intensity or maximal statin, and the various drugs are given here. Like we can give maximal statins to bring LDL cholesterol 70 or below. If you are not able to achieve with maximal statins, 40 to 80 milligram atorvastatin, 20 to 40 milligram rosuvastatin, we may add ezetimibe if needed. Now, if you cannot achieve, we have a new drug today called PCSK9. We'll discuss it in the discussion. Now, but before giving this drug, we must have the statins at the maximal dose. Ezetimibe already given before starting this drug. Very expensive drug and not indicated ordinarily. I'll repeat again, not indicated in our country ordinarily. Now, if the ACVD is not a very high risk and age is above 75 years, we have to initiate moderate or high intense statin, that is atorva between 20 and 40, and the rosuva between 5 and 10 and 20, and we continue the high density intensity statin reasonably in the class 2A region of evidence. If the person below 75, you can start high intensity statins if your goal is to maintain LDL cholesterol above 50%. If high dose statin is not tolerated, use moderate intensity statins. If maximal statin you are not reaching 70, you cannot ezetimibe or whatever you find reasonable. Now, in 2019, the American College of Cardiology and AHA guideline on the primary prevention of cardiovascular disease, you find that we have to assess the primary prevention. Ordinarily, the statins are not indicated before 19 years of age. I'll repeat again, ordinarily, statins are not given. I do not give. Guideline do not also recommend you should not use statins, say 18 and below years of age. But if you're dealing with a primary prevention, you have to assess ASCVD risk in each age group, and then one can give. We'll not could discuss this, but for each other age group, you have to estimate the lifetime risk. I'll be giving the table at the end to encourage the lifestyle to reduce ASCVD risk, and if not, then you have to start therapy. And we have seen that what are the various types of risk. I don't go details of it. If the LDL cholesterol is above 190, no risk assessment, you can directly give high intensity statins. If the person has diabetes mellitus and age between 40 and 75 years, moderate intensity statins can be given. The evidence is class 1. Here also evidence is class 1. If the diabetes mellitus between 40 and 75 years, you may risk assess to consider high intensity statins, and age more than 75 years, you can clinical assessment and the risk discussion with the patient. So dear friends, you find in the 2019 European and EAS guidelines and lipid modification to reduce cardiovascular risk, the task force has again classified same, the people at the low risk who do not have a risk factor, moderate risk, high risk, and very high risk, and you find that the that how much reduction you must achieve from the baseline for the LDL cholesterol given here. I'll be passing on this presentation to Rita Madam and Dr. Neeraj from the HiGlance. This can be shared with you all, this presentation, which clearly delineates how much, what should be goal. But to make a long story short, I'll give a very simple If a diabetic, type 2 diabetic, the goal is to have LDL 100, to have triglyceride below 150. If the person is at very extremely high risk patient, you can go up to 50. Severely high risk patient 70, or you can go up to 100. This is very simple approach. I personally feel that we must have simple approach. You know, we have got so many guidelines. I will ask Narsiman. We have again published guideline in November 2020 in JAPI, November 1st. But you see, the guidelines are not, this is my personal opinion. I don't want to cast any opinion, but my personal feeling is that perspective and an impression can be fallacious, that we have to extract from every guideline that I have tried to do. Target diabetes below 100, extreme risk below 70 at least, but you can go up to 50, and some areas you can go up to 30. I'll show it in a minute. For the high risk patient, you have to maintain at least definitely below 100. And for there are three concept change about the lipid lowering strategies. Number one, you must start lipid lowering very early. If you lower lipids from the very beginning, you prevent lesion formation. This 2019 guideline. Concept change two, treat aggressively. Don't treat hyperlipidemia haphazardly. People take drugs for the heart failure. I'm referring to SGLT2. People take DPP4. But what has changed the scenario of the heart attacks coming down by 1/3% is statin. And the anti-triglyceride drugs do not have the clear-cut evidence that it brings down the heart attacks, but there are indirect evidence. I'll come in a minute. Concept change to LDLC elimination in the blood, treat more aggressively from desirable to the target. I have told you target is 55, 70, 100. And change three, whenever necessary, freely use combination therapy. Statin and ezetimibe is the best combination. And if you can afford, patient can afford, give PCSK inhibitor for the LDL lowering to the lower cardiovascular risk. Dear friends, I was referring to this slide. I'll pass it out again to you through HiGlance. You find in 1988, the 88 goal was 130. 93, it came down to 100. It remained 100. 2004, it came down to 70. And in 2010, it was 70. And today, if you look to the very high risk patient, which was 70, has come down to 55. So we say lower is better, but not lower than 55. A very small segment patient, you can go up to 30. Dear friends, I am showing this to show that we do not achieve the target, we do not intensify the treatment, and I'm not very serious about it. Before I give my last slides, I'll tell a story. There are two American presidents who died of two diseases. One American president died of tuberculosis because anti-TB drugs were not available. The streptomycin came in 1945 and the person died in 1942, 43. But the other president died because of hypertension. Because that time Pickering and Platt, two hypertensiologists, were arguing whether hypertension were treated or not treated. In the meantime, the American president died because of hemorrhage. Dear friends, we have in our armamentarium wonderful drugs to treat dyslipidemia. We must use it absolutely. Dear friends, the progression of the latest guideline is last but one slide for me. I'll tell you that in 2016, we had type 2 diabetes mellitus, no additional risk factors, no evidence of anything else. So we maintain at about 100. Our target is to maintain below 100. And less than 70, without any CVD, more than 40 years of age, or with one CVD risk factor, and with CVD or CKD, we want to maintain less than 70. In 2017, we said without risk factor, even in high risk patient, or with one risk factor, very high risk patient, maintain at below 70, below 55 extreme risk. So remember these three numbers. If there is low risk type 2 diabetes, some guideline says that it can be 2116. This is 2019 ESC and ES guideline, below 116. But the majority guidelines say below 100. if there is a high risk patient below 70, extremely high risk patient below 55, and some patients, I have given you the patients where you can go below 30 or up to 30 or 30 to 50, below 40 are the people who have 10-year ASCVD risk more than 20%, multiple risk factors, very high risk, and were above 40 years, 40 and 50 and 70 years of age. So this says how the latest guideline have progressed. Dear friends, this is the comparison of the 2019 versus 2016 statin guidelines for primary prevention, and it says that you need a very small number to treat to prevent the heart attacks in these patients. Dear friends, this is the Lipid Association of India LAI expert consensus statement on the managed dyslipidemia in India in 2016. You see, it has also undergone this one in 2018, 2016. It said patient requiring ASCVD risk management, pre-existing ASCVD, diabetes with 2 other risk factors, familial homozygous hypercholesterolemia, high risk, more than 3 major ASCVD risk, or more than one or more high risk features, count number of major risk factors, look for other high risk features, and then you stratify moderate risk with 2 major risk factors, low risk, and estimate lifetime risk. And you know, you will see here that I like this way, that if the LDL cholesterol in very high risk, maintain below 50, non-HDL cholesterol below 80, high risk maintain below 70, below 100, moderate risk below 100, below 130, not HDL, non-HDL cholesterol together, low risk below 100, 130, and the drug therapy you consider preferably by all in very high risk groups. And you know, the drugs are given here, what drugs should give, and after an adequate non-pharmacological treatment can be given for at least 3 months. You can give exercise, you can give walking, you can burn cholesterol, but beyond it, treatment is a must. Now this is the proposed low-density lipoprotein cholesterol goals for secondary prevention in India with focus on PCSK9 given by Lipid Association of India. It says almost the same thing, almost the same grip, and also there are other ways that you can bring it out, like optimal control of diabetes and hypertension. Where do you use the high intensity statins, etc. As I told you, I want to keep my presentation case in simple and straight. So these are the last 2 slides by again Lipid from India in 2020. Now one has to identify subjects with dyslipidemia. We have to increasingly use and modify the dose of statins in suitable subjects, achieve the LDLC goal, identify and apply the lipid markers like Lp(a) and ApoB for risk stratification and control of vascular inflammation. So it also said that we need lower LDL goals. As I told you, I'll repeat again. Low use of LDL-C cholesterol alone may underestimate severe risk in subjects with atherogenic dyslipidemia. Therefore, today we have the role of the triglyceride coming more and more into play. Hypertriglyceridemia need to address residual risk that may persist even after high intensity statins therapy has been given. Statins also bring down the triglyceride, but the drugs are there. I think the icosapentaenoic acid, the Vespa, which is coming not yet in the market, the reduced it trial showed that this drug is beneficial, and also the fibrate therapy had shown the beneficial effect. But to make a long story short, there is no direct evidence that fibrates can affect the heart attacks. But it remains that if the high triglyceride continues, to residual risk that may persist even after high intense statin therapy, which may be enough to bring down triglyceride, or in association with icosapentaenoic acid, Vespa, or you can give the other drugs. Universal screening for the Lp(a) and to estimate severe risk. ApoB will clearly categorize these patients and may be measured. I don't say universally. Non-HDL cholesterol is a co-primary target, as important as LDL cholesterol. Monitoring of the non-HDL cholesterol is a simple practical tool for treatment decisions. The clinical judgment is of paramount importance. In individual case, and all decisions must be taken after counseling and informing the patient in detail. It must shared decision. Otherwise, a lifelong treatment cannot continue. Now I have given at the age the various drugs that are available. Statins, these are not used much. Bile acid sequestrants, cholesterol, niacin. I told you the risk reduction is limited. Bile acid limited. Fibrates, I've written no because that's the current evidence. Ezetimibe, yes, it has great benefit. PCSK inhibitors, we have three like icromab, evolocumab, available in our country, but very, very, very expensive. It is yes answer. Icosapent, this is a wonderful drug for the triglyceride. The answer is yes. The bempedoic acid, it is now it says it is in trial, but now it is over in trial. It has been approved by the FDA, not available in our country. I will not discuss the other drugs like iclosadine and the ezonucam, which is going to come in the market. Dear friends, therefore, how do you monitor the therapy? We monitor the therapy before starting the lipid lowering drugs. At least 2 measurements are made. I do it fasting, but fasting is not a must. With an interval of 1 to not 12 weeks, 1 to 3 weeks, with the exception of conditions where concomitant drug treatment such as ACS and very high risk patients should immediately start. How often patient lipid should be tested after lipid lowering drug? I'll say about 12 weeks, 3 monthly after starting the treatment, and after adjusting the dose until within the target range. How often should lipid be tested once a patient reaches the target range? Annually. I think once target is achieved, annually is enough. And it is also said that lipid status to be reassessed 6 weeks after therapy or 12 weeks after therapy, and every 6 to 12 months thereafter. The interval depends upon the particular case. Dear friends, as I told you, I'll end by saying that I've given you simple numbers, name of the simple drugs. Nobody can forget the statins. Nobody can forget the atorvastatin and the rosuvastatin. Nobody can forget the reduced the finding of the icopentine. Nobody can forget the fish oils, which are beneficial. Nobody can forget the fibrates, phenofibrates, and one may not give the drugs. I mean, the niacin has not stood the test of time. It may raise HD a little bit, not stood the test of time. And I've given you what is available today, but a simple outline how to manage dyslipidemia. Thank you very much. Thank you very much, dear friends. As I told you that we'll be having questions at the end. At this point, I'll see what are the questions because we'll be having a panel discussion. We'll have for each speaker only 2 questions. Whatever question has come in the chat box, I think the one of the question in the chat box it has come is asking about what is lipitension. Lipitension is a term currently described as the hypertension lipid together as a comorbidity of diabetes. It's called lipitension because is a hyperlipidemia occurs in hypertension, and diabetics is a disease of comorbidities. Both do occur. We're going to discuss hypertension. I'll not put the cart before the horse, but I must tell you that lipitension is a term popularized to discuss about the hypertension and lipid together. One must look, if one is there, look for the other and treat adequately. The second question, if the target is achieved, shall I stop the treatment? No, you cannot stop if you stop the treatment, it will go higher. So the lipid treatment must be continued as long as possible. I think there are a few other questions which I'll take up during the discussion. I will not discuss it now. Now it's my great, please put your questions together. We'll be having the question answer session at the end. Dear friends, it's my great pleasure and honor to invite Professor Dr. S.N. Narasimhan, who has been decorated by the Master Teacher Award, a professor of professors at the Stanley Medical College. He's going to talk to us on a topic which is of paramount importance: management of hypertension in diabetes, current recommendations from evidence to practice. He is the president of the national president, all India president of the Indian Society of Hypertension. He is the vice chairman of the LAI, and the adjunct professor at the MGR University, and he has many things to his credit. But I must tell you, his diction, his delivery, mastery over this subject is amazing. Dear friends, I have great honor in presenting to you my dear friend Dr. S.N. Narasimhan to speak to us about a very important topic. As I announced now, it's a very important topic: management of hypertension and diabetes. It is evidence to practice and the current recommendations. Dear friends, I present to you Professor Dr. S.N. Narasimhan. Please write down your questions. At the end of panel discussion, we'll take up some floor questions, time permitting. Over to SNN.
Sir, thank you very much. Can you unshare your screen, sir?
I'll answer right now. 1 minute. Yes.
Can you see my slides, sir?
Yeah, it is visible. Make it full screen. Yeah, now it is full screen.
So, good evening, everyone. Respected chairman and speaker of this particular scientific session, Professor A.K. Das, and other speaker, Dr. Bharat Shah. I am really very happy to get associated with these eminent people here for a scientific session. And I must thank Professor A.K. Das for showering praising words on me. Let me now try to tell you something about the management of hypertension in diabetes. What are the current recommendations from evidence to practice? Hypertension is the most common condition seen in primary care. It leads to myocardial infarction, stroke, and renal failure. It is not uncommon to see people with hypertension to get into complications like atrial fibrillation, peripheral arterial disease, and aortic dissection. Never forget to think about a common complication of hypertension, that is dementia. Otherwise, you will be sending your patients unnecessarily to the neurologist. Death occurs if not detected early and treated appropriately. This is a scenario which got projected from the International Society of Hypertension. As per the data in 2010, 1.3 billion people seem to be suffering from hypertension. Out of this, majority of them are from lower middle income countries, 1.04 billion people. Whereas 349 million people are from high income countries who suffer from hypertension. This is the global scenario which actually got published in Journal of Human Hypertension in the year 2014 as well as in 2018. The estimated prevalence globally is 26%. Indian prevalence revealed that overall prevalence of hypertension in our country is 29.8%. The prevalence of hypertension is about 33% in urban India and 25% in rural India. 1/10 of rural and 1/5 of urban Indian seem to be hypertensive population have the BP under control. This is actually a data which I collected from the district level household survey of an annual health survey. The age-adjusted prevalence of hypertension in men and women. In men, it is marked in blue. In women, it is marked in pink. The state where I am coming from is Tamil Nadu. Is here somewhere here. 16% is the prevalence in Tamil Nadu in males, 8% in females in Tamil Nadu. Rest of the states, the figures are given here. There are a number of cardiovascular risk factors which are seen in association with hypertension, overweight and obesity, including metabolic syndrome is 40%, lipid disorders are about 30%, type 2 diabetes in association with hypertension, to start with hypertension-related diabetes, 15 to 20%, hyperuricemia in about 25% of patients with hypertension. There are about, as per the data projected in the year 2014, there are about 7 crore patients with diabetes. Now it is much more. More than the double the number as far as the hypertension is concerned, is about 15.2 crore patients. And if you combine hypertension plus diabetes, it is about 5.2 crore patients. Taking this important firm statement that every third patient with hypertension also has coexistent diabetes. If you look at this particular projection, you will be surprised to see that we have been witnessing the reduction of the systolic blood pressure right from JNC 4, 5, which started with the 160 systolic and GNC 4 and 5. After that, we were all very comfortable with ASH came out with the recommendation, International Society of Hypertension, JNC 7 came out, saying that 140 should be the systolic blood pressure goal to treat hypertension. Whereas the entire scenario got changed after the publication of Sprint trial in the year 2015, which changed the scenario of our approach, particularly the ACC-AHA guideline developers took into consideration this publication of a wonderful study, Sprint, which emphasized the role of reduction of blood pressure less than 120 systolic, which resulted in the beneficial effects in the cardiovascular outcome, not only in morbidity but also mortality. But of course, one has to remember the methodology that they were adopted to screen the people with hypertension and the follow-up these people done was entirely different from what we are practicing currently in our clinics. So taking that into consideration, people have analyzed and they said 120 of Sprint systolic blood pressure is equal to 130 of office blood pressure. Taking that into consideration and other evidences together, 2017 ACCH came out with a recommendation that the systolic blood pressure goal should be 130. International Society of Hypertension last year in 2020 came out with the recommendation that it should be around 130 is the systolic blood pressure goal. This is about the definition of hypertension. Anything that is more than 140 over 90 is considered as hypertension. This is a recommendation given by International Society Guidelines 2020. Fortunately, I was one of the external reviewer for ISH Guidelines 2020. Here, the normal BP instead of 120/80, it is considered as 130 systolic and less than 85 diastolic is considered as normal. High normal 130 to 139, 85 to 89. Whereas the grade 1 hypertension 140 to 159 and 90 to 99 diastolic. Whereas grade 2, anything that is more than 160 and anything more than 100 diastolic is considered as grade 2 hypertension. Now, just for you to compare the International Society of Hypertension guidelines, which was published last year, to compare it with the ACCHA guideline, which got published in 2017, you will be surprised to see normal blood pressure is 120 over 80 as per their guidelines. Elevated, in fact, though, there was one terminology called pre-hypertension, 120 to 139 and 80 to 89, which we are all remembering even now. That was removed by ACC-AHA guidelines. They told elevated blood pressure from 120 to 129 and stage 1 hypertension from 130 to 139. What was designated as 120 to 139 as pre-hypertension, they have divided into two groups. One is elevated blood pressure, number 1. Number 2 is a stage 1 hypertension. Anything that goes beyond 140, it is called a stage 2. What we call as hypertension 140/90, they call it a stage 2. So what is described in International Society 140 to 159 as a grade 1 hypertension, anything that goes above 140 is considered as stage 2 hypertension by ACCH. This is just for comparison for you to remember certain things. I need to tell you that people with type 2 diabetes, nearly about 70 to 80% of them are seen to be suffering from associated hypertension. If you take type 1 diabetes, 25% of them suffer from hypertension. The prevalence of hypertension, in fact, increases with age, type of diabetes, obesity, and ethnicity. In type 1 diabetes, hypertension, mostly it is due to underlying nephropathy, ongoing kidney disease. In type 2 diabetes, all of us know that the moment the patient gets into a chamber, and when you give a label that is become a diabetic, you'll also be surprised to see that he has got a coexisting hypertension. Diabetes and hypertension are typically components of metabolic syndrome. Let me now try to tell you about the hypertension, which increases the risk of complications in people with diabetes. When you compare diabetes with no diabetes, the cardiovascular disease 2 to 4-fold rise, ESRD 7-fold. When you concentrate on diabetic people with elevated blood pressure, compare it with only people with only diabetes, no blood pressure at all, the CHD is actually 3 times higher, stroke 4 times higher, retinopathy and nephropathy 2 times, mortality is 2 times. We need to remember one important message is that 75% of the people with diabetes die from cardiovascular diseases. Now, time and again, we have been showing this particular projection that epidemiological analysis show that any blood pressure more than 115/75 or associated with increased cardiovascular event rates, mortality in diabetes. For example, just see 115/75. If it reaches 135/85, with each increment of 20 millimeters of systolic pressure, at each increment of 10 millimeters of diastolic blood pressure, the risk of dying due to cardiovascular disease is twofold higher. Suppose somebody reaches 175 or 105, it almost comes eightfold increase when compared to 115/85. So this message actually has to be kept in mind whenever we see patients with elevated blood pressure or hypertension. I need to tell you something about isolated systolic hypertension, which is also commonly seen in elderly as well as in people with the diabetes. Look at this projection. This is effect of aging on vascular resistance as well as large vessel stiffness and the blood pressure. The one that is marked in green is the diastolic blood pressure. After the age of 55 to 60, it drops down, paving the way for an increase in the pulse pressure because the systolic pressure, which is marked in red, which is always going up as the age advances. So you do get the systolic blood pressure, which is very high. It is due to large vessel stiffness, whereas the diastolic blood pressure is due to vascular resistance, which comes down after the age of 55, 60, which paves the way for these individuals to have more pulse pressure. Having seen this, this is very, very important. Aortic stiffening and early wave refraction. Look at the young compliant arteries. Normal pulse wave velocity is 8 meters per second. During systole, the wave goes into the vessels and the arteries, capillaries, the reflected wave comes. By the time the heart also becomes relaxed, diastole occurs. There is a good ventricular vascular coupling. There is an increased coronary blood flow because the heart is in diastole. Now look at a person who is elderly. There is stiff arteries with isolated systolic hypertension. There is an increased pulse wave velocity of 12 meters per second. The moment the systole occurs, the wave goes there. Quickly it comes back, rushes back to the heart. The heart has not relaxed. Still in systole, that shows that there is a ventricular vascular mismatch, which gets reflected in increase or augmentation of the central systolic blood pressure during late systole. Having seen this mechanism, let me try to tell you that not only the microvascular complications are going up, and the systolic pressure goes from 115 to 165 as it is projected here. From 8, it goes to 24 per 1,000 patient years, whereas the macrovascular events from 18, it goes to 37 when it reaches 165 millimeters of mercury. This is again another important projection with respect to the change in the albuminuria over 1 year, which predicts the cardiovascular events in diabetic patients. There are two varieties. One is a regression or the slow progression. People in whom the albuminuria is not going beyond 30, it is less than 30% increase annually. That means the fellow is probably having a regression or a slow progression. Annually, the albuminuria was analyzed. The one that is marked at the lower bottom or the one is marked with the red, which shows the albuminuria is increasing more than 30%. The survival benefit is lost. The person, they die quickly because of the increasing renal morbidity and end-stage renal disease. Microalbuminuria is delayed or reduced by treatment of blood pressure. Randomized control trials done in diabetic population, both in normotensives as well as in hypertensive individuals, unable to demonstrate consistently that proteinuria reduction is also accompanied by a reduction in the heart cardiovascular outcomes. Let me now try to talk to you about interventions. The most important intervention is the lifestyle modification, which needs to be addressed every time when the patient walks into a clinic. Weight reduction for those people who are very obese or overweight or obese people or people with metabolic syndrome. Adopt a DASH eating plan, very important, cutting down the salt intake to 2,300 milligrams of sodium or 5 grams of sodium chloride as it is projected by WHO. Then increase the content of grains, then the vegetables, fruit consumption. Increase the potassium consumption by usual normal food sources. Increase the physical activity. Moderate alcohol consumption in those people who are in the habit of taking it. Stopping the smoking probably will help these people to bring down the blood pressure also, and then adverse cardiovascular events can be brought down. This is good study, just called as a ready-made study, particularly focusing attention on diet and the primary prevention of cardiovascular disease. They've included people with the diabetes, with hypertension, with the dyslipidemia, older people, overweight people with a family history of premature CVD. At baseline, there is no cardiovascular disease at all. One arm received Mediterranean diet with a supplemented with extra virgin olive oil. The other arm received Mediterranean diet with supplemented with the mixed nuts, compared to the control diet, which was advised was given only to the dietary fat. They were all followed up for a period of 4.8 years, which reflected a good amount of cardiovascular outcome. Those people received the Mediterranean diet with nuts as well as the virgin olive oil has shown a reduction of cardiovascular events to the extent of 30% compared to the control diet. Now, this is a valid information that we had obtained from the UK PDS study. Every 10 millimeters reduction in the blood pressure can result in 12% reduction in any diabetes-related complication. Tight control of blood sugar, tight control of blood pressure was compared in the UK PDS study. Here, tight control of blood sugar resulted only in 5% reduction in the stroke, whereas tight control of blood pressure resulted in 44%. The same thing is true, any diabetes-related 0.12% reduction for tight glucose control, whereas for tight blood pressure control, 24% reduction. What about deaths? Deaths again to 32% reduction for a good tight control of blood pressure. This is a study which all of us know, a CORD study. It had 3 arms. One is a lipid lowering arm, the other one is a glucose lowering arm, the third one is a blood pressure lowering arm. The blood pressure lowering arm, which I would like to concentrate, one arm received intensive treatment to keep the blood pressure, systolic blood pressure less than 120 with an aggressive management, multiple drug therapies, the standard one less than 130. You can just see people who received the intensive therapy who had brought down the systolic blood pressure less than 119/64 had a lot of problems, including acute kidney injury, and then the postural hypotension, and the electrolyte disturbances, falls had occurred, increase in the cardiovascular risk also had happened, except for the fact that there is a reduction in the stroke and fatal stroke in this group of patients with a CORD study, thereby showing you are not expected to reduce the blood pressure, systolic pressure, particularly in people with diabetes, less than 120 millimeters of mercury. Having seen this, I think I should project this particular study called Accomplish, which started talking about the reduction of the primary endpoints as well as CV death onto the right side. The primary endpoints actually came down when you bring down the blood pressure from 140 to 130, from 130 to 120. So if keeping the levels between 120 to 130, you get a maximum reduction in the primary endpoints. Whereas when you go down below 120, you can see that there is an increase in the cardiovascular event, the primary endpoints actually go up, thereby showing the Jacob hypothesis is still valid. The second one, as far as the cardiovascular death is concerned, you can just see 140, less than 130 to 140, reduced. Whereas when you come down to less than 130, above 120, there is a marked reduction in cardiovascular death. Whereas when you bring it down below 120, there is an increase in the cardiovascular death. Again, emphasizing the role of the Jacob hypothesis, and one should be very careful in reducing the systolic blood pressure less than 130. This is the data that we obtained from value trial, which had stressed the importance of early control of blood pressure. People who reach the control of blood pressure within a matter of 6 months after starting therapy has shown beneficial effects when compared to people who did not reach the target level of blood pressure. There was a reduction in fatal non-cardiac events, fatal and non-fatal stroke came down, myocardial infarction came down, hospitalization for heart failure came down. So the message is very clear. Earlier the better, and at the same time, you should see that the patients reach the goal within a matter of 6 months. That's a message what we get from value trial. But now we have realized that it should be brought down within 3 months of treatment. That is the recommendation what we made in the International Society of Hypertension guideline. Within 3 months, you should reach. This is actually, we have seen individual trials. Let me now try to take to a meta-analysis, which is actually for you to see properly. All the small letters I have magnified now. Number of studies 123, participants more than 61 lakh patients, 6,13,000 patients. 10 millimeters reduction in the blood pressure resulted in major CVD with 20%, CHD by 17%, stroke events came down by 27%, hospitalization for heart failure 28%, all cause mortality came down by 13%. What? What level? 130 milligram at less than 130 millimeters of mercury. Systolic blood pressure, all these people have shown benefit. Who are the people who have shown benefits? Look at the one that I've circled. People with the diabetes have shown benefit. People with the stroke events shown benefit. People with other cardiovascular events like CKD, including CKD, heart failure, CHD individuals or CVD, all of them have shown benefits if the blood pressure is brought down to levels less than 130 in this meta-analysis. Let me now try to take you to the renin-angiotensin aldosterone system, which becomes active not only in the initiation of the endothelial dysfunction, which aggravates atherosclerosis, which aggravates blood pressure, which aggravates all sorts of complications in people with diabetes. All of us know about how things are getting produced. ARBs are the best drugs when compared to ACI. We feel that. Is it so? As far as the stroke is concerned, yes, there is a definite decrease in the stroke events compared to the ACI. So ARBs are good. ARBs and MI, initially people had a fear to use this drug because of the fear created in the Lancet issue, saying that it can increase the myocardial infarction. Now, of late, we have realized that it is not true and it is neutral. It does not increase the myocardial infarction incidence. Let us now ask this question, ACI or VRB, which one is superior, one over the other? They are equal. Anti-hypertensive effects are equal, ACI and ARB. ARBs are excellent drugs for hypertension, proteinuric disease, heart failure, equal but no better than ACI. Please remember that. But one thing that differs is that the compliance becomes excellent with ARB. The compliance and adherence to the treatment becomes excellent. At the end of 12 months, you can see the ARBs, the compliance about 68% compared to ACI. At the end of 48 months, 51% of the patients still continue to take ARBs when compared to the other drugs, thereby showing the compliance becomes excellent. Cough incidence is less with ARBs. Angioneurotic edema is less with ARBs. ARBs is long-acting, can be given safely once daily, but not the usual pills, which need to be given sometimes 2 times daily. The combining ACI and ARB, not recommended at all. Altitude has shown negative effects, should not be combined. What about the role of diuretics? CHEP and CISTU trials have emphasized the role of diuretics even in people with diabetes who have shown beneficial effects. Allahabad study is the largest study. 48,000 patients were recruited for this study. All 3 drugs, chlorthalidone, amlodipine, lisinopril, are same in producing the beneficial effects as far as the cardiovascular events are concerned. But advanced trial, which has shown the usage of perindopril and ACE inhibitor plus indapamide, a diuretic, thiazide, like diuretic, has shown benefits mostly in the microvascular complications rather than macrovascular disease. Till that time, we were not having any idea about treating patients above the age of 8 years. People who were octogenarians above the age of 8 years, they were all recruited for this study called HiGlance study, which has shown beneficial effects in using 1, perindopril, 2, indapamide, either in combination or monotherapy. They have seen beneficial effect, everything onto the right side, onto the left side. Stroke events came down, heart failure came down, stroke deaths came down, CV deaths came down. Which one is better? Is it hydrochlorothiazide or the chlorthalidone? This question actually gives answers from all of us. Mr. Fit trial, multiple risk factor intervention trial, where people received hydrochlorothiazide, chlorthalidone. People received hydrochlorothiazide, switched over to chlorthalidone. The one that is marked in blue color tells you that after the change, you can just see chlorthalidone group is actually the brown one, which shows more benefits when compared to hydrochlorothiazide in all events of CV events, acute MI, other CV events, other CVD, everywhere. Chlorthalidone has got almost a pleiotropic effect, reduces the nocturnal blood pressure, and reduces the early morning surge in the blood pressure. So there's much more superior when compared to hydrochlorothiazide. Role of beta blockers, we know that it increases the new onset diabetes, more so with the diuretic combination. We know that atenolol in the trials, many trials, has shown an increase in the stroke events. So atenolol should not find a place in the therapeutic armamentarium of treating patients with hypertension, particularly when you concentrate on beta blockers. Today we have an understanding about the usage of the beta blocker. Never use it in the beginning. Zero. When a patient has got a complication, you need to use beta blocker. When he has arrhythmias, when he has coronary artery disease, when he has congestive cardiac failure, whenever there is a sympathetic drive, which is very high in younger people also, you can probably use beta blocker. Whereas uncomplicated hypertension, there is no place for beta blocker as per the evidence available today. Carvedilol is again a good beta blocker, alpha and beta blocking agent, good for hypertension with heart failure, reduces the microalbuminuria. A good drug in combination with the RAS blockade reduces albuminuria, slows down the progression of nephropathy, improves insulin sensitivity, useful role in CAD and heart failure. I think I need to tell you this drug is not being utilized properly by the diabetologists. Nebivolol is yet another beta blocker which has proved its efficacy and safety in seniors trial, again, which increases the nitric oxide production in a vasodilator, reduces oxidative stress, and the incidence of new onset diabetes is very low. Calcium channel blockers, it has done wonders. Ascot trial has shown the way for us to proceed further with the usage of amlodipine, which has shown in combination with perindopril and ACE inhibitor compared to the atenolol and diazide. All events, primary endpoints, secondary endpoints, tertiary endpoint, everything is in favor of amlodipine plus or minus perindopril. Accomplished study again shown benazepril, an ACE inhibitor plus the amlodipine is better when compared to benazepril plus hydrochlorothiazide. You can see 20% reduction. So accomplished study, why I'm talking about accomplished study? 60% of the patients with diabetes were in the accomplished study. So we need to remember that. Aldosterone blockers, one is spironolactone, the other one is eplerenone. RAL study and efficacy study. RAL study, efficacy study are very important studies to talk about the efficacy of these aldosterone blockers. Efficacy study, eplerenone was used good in combination with ACI and CCB, a good drug which can be used to improve the diastolic function, reduces the proteinuria. Again, very useful in diabetic nephropathy, a good add-on drug which removes all sexual side effects of the aldosterone and spironolactone. So when you talk about the individual drugs and the combination drugs, then you will be surprised to see, if you take all the trials into consideration, you will see that many trials had used not less than 2-3 drugs or sometimes 4 drugs to bring down the blood pressure to the goals what these investigators wanted in their trials. ADA way back 2015 itself started talking one important message out of 255 patients analyzed in one study. Administer one drug or more anti-hypertensive drugs during nighttime so that it will take care of the nighttime increase in the blood pressure so that early morning surge will not occur and so patients will get the benefit. Still valid, still recommended in 2020 also. People who are diabetic, when they are receiving these drugs for hypertension control, are they getting the benefit? Yes. Look at on the left side, everywhere you get a benefit. Mortality benefit, yes. Cardiovascular disease benefit, yes. And then the stroke events came down by 27%. Heart failure admissions came down by about 14%. Renal failure, yes. Retinopathy comes down. Albuminuria comes down. So you can just see the benefits of reducing the blood pressure in people with diabetes alone has shown a market benefit which got published in JAMA in 2015. Resistant hypertension, all of us know. I don't want to give you the terminology, how you should define resistant hypertension. More than 140/90. You have used 3 drugs, one including the diuretic, still the blood pressure is high. Think about the other causes and maximally tolerated doses, which you should have tried in these patients. Only then you call that as resistant hypertension. How to proceed? The best thing is to follow International Society of Hypertension guidelines. Very simple to follow. One step, A plus C. Start with the low dose combination as a first step. The second step, give the full dose combination A plus C. Third step, fellow is not responding, A plus C plus D, diuretic, triple dose combination. Of course, you should advise a single pill, not two drugs or three drugs. Step 4 is a resistant hypertension, where you combine it with a spironolactone starting from 12.5 to 50 milligram. You can use even doxazosin alpha blockers. You can use the other beta blockers as the last step in the management of hypertension on not on a regular basis. So, ladies and gentlemen who are watching this particular scientific program, including our chairman, Professor Ekhetas, I need to tell you this is simplifying the combination, the management of hypertension. One is ARB, better when compared to ACI. Diuretic has shown the path for us to proceed further in combination drugs. CCB is an excellent combination with ARB and diuretic. But if you want to start your patient, probably ARB and CCB will be the first drug. A plus C will be the first drug that should be probably implemented. Message from my end, ladies and gentlemen, for all clinicians who are watching this particular program. We need to be committed. We need to be aggressive, not to curb just hyperglycemia, but to concentrate on every possible risk factor, like your lipids, like your hypertension in people with diabetes, right from the time of diagnosis. Thank you very much, ladies and gentlemen. Thank you very much, Chairperson.
Professor Narasimhan, thank you very much for a very lucid, very clinical and practical talk, which I'm sure will be, is absolutely a great, message for all the clinicians. We'll come back to the question a little later, but
Yeah.
I must tell you that this has been a very nice talk and far-reaching consequence and lot of practice-changing points you have said. We'll come back to a lot of questions that has come in the chat box and the question box. In the meantime, it's my great pleasure and honor to invite Professor Dr. Parag Shah. Professor Parag Shah is from the city of Ahmedabad. He is an endocrinologist of great repute. Dear friends, I must tell you that I am associated with Parag for a very long time. In many, many meetings, scientific associations, in the scientific conventions, in the conclaves and summits, we have been together. He has a great clinical acumen, and you must see to believe the amount of patient service it does. Being a DM, being a MD, he sees the patients left, right, and the middle and delivers the care. The uncrowned king of Ahmedabad, uncrowned king for a greater part of our country, western part of our country, in treating diabetes. I'm very happy to present you Dr. Parag Shah, very eminent endocrinologist with a MD and DM and excelled in many fields in diabetes, in endocrinology in general and diabetes in particular. And he's going to speak to us on a very important topic, the oral hypoglycemics in the management of in the management of type 2 diabetes, initiation, escalation, and optimization. Parag, all is yours.
Thank you very much, sir, for your very kind words. It's always your blessings and well wishes.
You can share your screen now.
Yes, sir.
Yeah.
What I would be discussing would be very practical aspects of how to use the OAD, how to start, how to escalate, and how we should be aiming to have the HbA1c target to the normal. This has been discussed. This is a typical Asian Indian phenotype. We are all thin fan Indians with lots of insulin resistance, even with a relatively less BMI compared to Caucasian parts. And apart from that, unfortunately, we got a beta cell dysfunctions. We start with a reduced beta cell function, and our beta cell functions probably deteriorates quite fast. So probably it is the time for all of us to come together and target the HbA1c to the lowest possible right from the day one. It is like a T20 power play. Start aggressive to win the game of a diabetes. We all know the omnious octet of pathophysiology behind the hyperglycemia in type 2 diabetes. And we all know we got an excellent agent in last 1.5 to 2 decades, which tries to correct the many pathophysiology which is present in type 2 diabetes. And we all know that apart from insulin deficiency and insulin resistance, there is a good contribution of other pathophysiology, and we got a excellent agent. So there is more the agent, more is a confusion probably in the mind of the clinicians.
Correct.
Which one to start, when to start, how to start, which one to choose. So apart from guidelines, I will discuss more of a clinical cases and why I would choose that particular agent as a first preference, and I will give some data why that agent should be preferred. We all know the profiles of anti-diabetic medications based on the hypoglycemia risk, weight, renal, GI side effects, most importantly congestive heart failure, cardiac ASCVD, effects on the bone, and the risk of the ketoacidosis. So we got a excellent representation of each agents and its potential benefit and potential concerns before we prescribe any medication. I think we'll discuss one by one. So our goals for diabetic management is not only to have the good glycemic control, but we want to prevent acute and chronic complication. We want to have the minimal hypoglycemia and weight gain. We want to have the improvement in the quality of life. Most importantly, we should not be glucose centric, as has been described by Professor Das. Also, management of comorbid condition, and most importantly, hypertension and dyslipidemia, ultimately preventing vascular, metabolic, and immune complications with less glycemic variability. So we approach to the management of hyperglycemia right from the A1C target to the which agent we will choose will depend upon lots of factors. That is why we should be individualizing our management strategy. Longer the disease duration, we will be less aggressive because the benefit would be less to be too aggressive. But newly diagnosed diabetic patient, we should be very, very stringent to have the A1C target, which is less. Similarly, long life expectancy, very strict criteria for A1C reduction, less comorbid condition, non-established atherosclerotic disease, and cost and the other factors also we always consider. Unfortunately, in spite of excellent agents available with us, the ground reality is been described here. Most of our patients has HbA1cs ranging between 8 to 9% in spite of having a good oral anti-diabetic agents available with us. It is very, very important. Any A1C drop of even 1% brings down micro and macrovascular complications clinically and statistically significantly. So it's not a bad idea to bring down A1C from 9% to as low as possible, but even 1% A1C reduction is always going to be beneficial. We'll discuss some brief about the overview of the oral anti-diabetic agents and what are the pros and cons. Our oldest friend metformin, only problem is the gastrointestinal side effect and very minimal percentage of the patient, and some patient may have vitamin B12 deficiency. Advantage is extensive experience, cheap, usually very well tolerated. UKPD's follow-up data also showing reduction in the cardiovascular events and good HbA1c reduction capacity. And probably the mechanism is such that apart from reduction in micro and macrovascular complications, there are data that it decreases overall mortality and decreases even the cancers. Sulfonylurea, one of our oldest friend, extensive clinical experience of all of us of more than 5 decades.
Parag,
Yes, sir.
Go back to the slides. Can you go back to the first slide, or you will start little later? Slides are not coming.
Okay,
you have to go back to the first slide of your slides. So Parag,
sorry,
no, not yet.
Visible, sir?
It is. You have come to the tag. No, not yet. Can you go back to the first slide?
Yes, sir.
You just go up. It is coming in the thank you slide 35. Am I correct, SNN? Are the slides visible? Is the slides visible to everybody?
Yes, yes, sir. Yes, sir.
Can you go back to the first slide, or it is?
This is the first slide, sir. Should I start from here again? Or?
Yeah. You can start where you are. Just share it. Share it again.
Okay.
Thank you. Thank you. Thank you. It is coming now. Okay. You can go to the top.
Yes, sir. Yes, sir. So sulfonylurea, we got excellent experience of our own. It is robust glycemic control, and reduction in the microvascular complications. Despite very well established benefit, their place is in therapy, not in India, but in the Western literature, is inappropriately being overshadowed by the newer therapeutic agents. Modern sulfonylureas like glimepiride and gliclazides are cardiovascular neutral, more or less weight friendly. Though the chances of hypoglycemia are there, but significantly less compared to the old class of sulfonylureas available with us. So potent A1C reduction, low cost are the biggest advantage, but we have to be careful about the risk of hypoglycemia. Pioglitazone, I think one of the best insulin sensitizer available with us. The problem is weight and the edema, and those patients who had a underlying hidden or the known heart failure, there will be worsening of the heart failure and some data, anecdotal data about some increased risk of the bone fracture. But it's a very, very important agent from Indian perspective because we start with a insulin resistance, even with a BMI as low as 23. Rarely it causes hypoglycemia, good HbA1c reduction, excellent durable glycemic control, decreased risk of stroke and NMI in patient without diabetes and in patient with insulin resistance as demonstrated in the IRIS study. This is the IRIS study published in NEJM 2016, PIO versus placebo in presence of pre-diabetic patients. Significant reduction in all primary outcomes, including stroke, fatal, non-fatal stroke, myocardial infarction, fatal, non-fatal, and significantly decreased risk of converting from pre-diabetes to diabetes, and it shows a robust benefit. AGIs, we all know that we Indians have a high carbohydrate rich meals, which leads to the hyperglycemia postprandially. So advantage is a significantly reduction into the postprandial glucose excursion, dual mode of actions. One is the glucose absorption is prevented and it increases the GLP-1 secretions, no hypoglycemia, no weight gain. Acarbose has showed cardiovascular neutral to some data that it is cardioprotective. The only problem is the GI side effect and the frequent dosing. So consensus statement for Indian patients is one of the excellent agent for controlling the postprandial hyperglycemia in our Indian type 2 diabetic patient. We all are very familiar with the DPP-4 inhibitor, except Sexa and to a certain extent Allo. All are quite cardio-friendly, renal friendly, weight neutral, low risk of hypoglycemia, excellently tolerated drugs. Decreases the glycemic variability. Gliptin and AGIs are shown to reduce glycemic variability significantly. I think we all are now knowing SGLT2 inhibitor like our palms. Only problem is the cost and the urinary and genital mycotic infections. There are lots of advantage, sustained weight loss, good HbA1c reduction, durable glycemic control, effective at any stage of diabetes because of the insulin independent mode of action, least chance of hypoglycemia, good BP reduction, cardiovascular benefit for heart failure as well as ASCVD, mortality benefit and the renal protections. So there are multiple pathophysiology which is addressed by the SGLT2 inhibitor, and that is why it has shown data to show benefit in heart failure and the renal insufficiency even with the patients without diabetes. And that is ACE 2020 recommendation, HbA1c less than 7.5, first drug would be metformin, and according to the preference, GLP-1 or the SGLT2 would be the another group of the drugs if metformin is not tolerated, or if ASCVD risk is high, CKD risk is high. Dual therapy if HbA1c between 7.5 to 9. Preference is GLP-1 and SGLT2 inhibitor on top of the metformin. Triple drug along with the metformin, GLP-1, SGLT2 inhibitor. If A1C is very high, more than 9%, patient has an osmotic symptom, insulin, no osmotic symptom, dual or the triple drug therapy. This is RSDI ESI 2020 recommendations showing all the agents and their potential benefits and the concerns associated with it. So this is the latest algorithm indicative of high risk or established ASCVD, CKD or heart failure. You individualize the A1C target. If ASCVD predominates, GLP receptor or SGLT2 inhibitor as a first line. If heart failure or CKD predominant, SGLT2 inhibitor. If not tolerated or GFR of less than 30, then add GLP-1 receptor agonist. If A1C is not on target, you get a excellent other agents to add on. If there is a no SCVD, then minimum risk of hypoglycemia, non-secretagogue group of the drugs, minimum weight gain, then GLP receptor agonist or SGLT2 inhibitor. Cost is an issue, then glitazone and the sulfonylureas. So before we consider oral anti-diabetic agents, we should consider age, weight, ethnic difference, duration of diabetes, life expectancies, presence of comorbidities like CAD, heart failure, kidney disease, liver dysfunction, hypoglycemia, risk, how much patient's comorbidity would permit to take, and cost and the side effect barriers. So we will always have to individualize the treatment. So rather than having the old concept of stepwise treatment, we have to have the proactive approach of glycemic control. Start early combination therapy. Don't wait for a long period of time before add the drug with a different class to have the better HbA1c control. We will just discuss some cases. This is a 36-year-old gentleman, type 2 diabetic on routine health checkup, asymptomatic, no weight loss, no polyuria, no comorbid condition. BMI is 24.3. Family history, type 2 diabetes to the father. Fasting is around 153. Post meal 217. A1C is 7.4. So he's young. He's worried about his quality of life and longevity because he got a diabetes at a younger age. So what should be our target? Less than 7% or less than 6.5%? He's a young gentleman with a long life expectancy, no comorbid condition. I will bring down as low as I can comfortably put, like less than 6.5 or even less than 6% also. Along with lifestyle modification, which pharmacotherapy, whether we should give only metformin because HbA1c is not very high, it is only 7.5. So with a lifestyle modification and metformin, probably his A1c would be coming down by 6.5 to 6.8% probably, or we should be aggressive right from day one. And along with lifestyle, we should start the combination therapy. So against many guidelines, why not to start the combination therapy to start and stay for a longer period of time? So we started him on a Vilda metformin combination twice a day. After 3 months, sugar profile is absolutely fine. A1C is 6.3. What next? Whether we should down titrate, continue same? What should be our target? Yes, if patient is tolerating the drug well, let the beta cell be at rest, let the HbA1c remain around 6%, and we should be continuing the same medication. Just like a statin therapy, we have started, patient has achieved the target, we don't down titrate. Similarly with hypertensive, patient is tolerating well, hypertension is under control, well under the target, we continue the same. So why not to continue with the same medication for a long period of time? Does aggressive treatment late in the disease improve the outcome? No. With what we call the metabolic memory, early good glycemic control is the most crucial part. Even 1 year of good glycemic control gives excellent glycemic legacy, and bad glycemic control for 1 to 5 years leads to the lots of complication. Even Accord study showed that subsequent after 8 years of uncontrolled sugar, if you become too aggressive, probably you increase the mortality. So less aggressive control can be not beneficial, it might be harmful. So how can we treat the disease aggressively in its early stage? Start aggressive treatment with the drugs with a multiple pathophysiological targets. Good option to have the better HbA1c control. Better HbA1c control would put beta cell at rest. It will reduce the glucotoxicity. And one of the key features why the beta cell gradually fail is because of the gluco and the lipotoxicity. So if you take care of the glucotoxicity and lipotoxicity right from day one, we are probably aiming for a good beta cell function for a long period of time. So what we want the drugs combinations with least risk of hypoglycemia, weight gain, and well tolerated drug without increasing the cost too much. Because of the long term therapy, we have to consider the cost also as an important factor. And these are lots of data showing metformin monotherapy versus starting with a metformin and different class of the medications, showing a significant better HbA1c reduction than starting metformin as a alone. But which second line agents? One of the safest agent, well tolerated agent is the DPP4 inhibitor. The verified trial is the first and the only trial to investigate the long-term clinical benefits of early combination treatment, A1C baseline 6.5 to 7.5 versus metformin monotherapy. And you can see the baseline HbA1c was 6.9. You might not probably start any treatment. So one group was given Vilda metformin and one group was given placebo metformin, and one primary OHA failure where 2 A1C is more than 7% is considered to be the primary drug failure. Secondary drug failure is the 2 times A1C more than 7%. So those who have a primary failure with a metformin vilda are continued vilda metformin, but those who are placebo metformin are given the vilda metformin. So what happens? You can see the type of patient they have studied. Baseline HbA1c is 6.7. Duration of diabetes is 3 months. Hardly we see the patients with such a low duration of diabetes. And initial treatment failure, 49% relative risk reduction with the vilda metformin compared to metformin monotherapy. And patient on vilda metformin failed 2 years later compared to metformin as a monotherapy. What about the second treatment failure? Those who started with vilda metformin, compare later on starting vilda metformin, those who started vilda metformin had a more sustained A1C drop, and secondary drug failure rate was 26% less. So 60% of the patient could achieve A1C target of less than 7% if you started Vildamet right from day one, which is a good number. You started with the same medications, you continue for 5 years, and 60% of the patient could achieve the target of less than 7%, and 40% could achieve the target of less than 6.5. And along with that, though this is not a cardiovascular outcome trial, but it showed that adjudicated cardiovascular event was, though not statistically significant, but numerically less with those who were started with vilda metformin right from the day one. And that is why ADA 2020 says early combination therapy with specifically with vilda metformin can be a consideration to extend the treatment failure duration for a longer period of time. So this is a second case. 45-year-old homemaker female, symptomatic for last 2 months, polyuria, polydipsia, and some amount of weight loss, dyslipidemia for last 2 years, family history of type 2 diabetes, normotensive, premenopausal, sedentary lifestyle with walking of around 20 minutes, fasting sugar is around 172, postprandial is 232, and HbA1c 8.1, BMI is 23.5. So she is also relatively young, but more robust A1C rise, 8.1%, and some weight loss has started, and some polyuria, polydipsia is there. So what should we start? Whether we should start with a monotherapy with a metformin? What is our target HbA1c in her? Again, long life expectancy, no comorbid condition. I will go for 6.5 or less. Metformin as a monotherapy, 2 drug combination, because HbA1c is 8.1, triple drug therapy or insulin therapy. So we started with the glimepiride metformin combination because of the polyuria, polydipsia, suggesting weight loss, suggesting some insulin deficiency. So after 2 or 4 weeks, her sugar is well controlled. She gained whatever weight she has lost. And after 8 and 12 weeks, sugar is well controlled. A1C is below 6.8, no hypoglycemia. What next? Whether we should continue same, decrease the dose, or switch to other therapy. There are lots of options available with us. We can decrease the dose of glimepiride from 2 mg to 1 mg, keep the metformin same, and just observe the patient. Or you can switch over now, the glucotoxicity is over, patient has gained weight, now switch over to some other therapy like gliptin metformin or pioglitazone metformin therapy. What about the data? Glimepiride and metformin, complementary mode of actions. Glimepiride improves the beta cell functions, metformin decreases insulin resistance, and efficacy of sulfonylurea in reduction in the HbA1c level is far, far superior compared to many of the other oral anti-diabetic agents. You can see here the sulfonylurea is reducing HbA1c by 1.2%. That is also we have observed that sulfonylurea is one of the key drug, specifically if the HbA1c is high to start with, patient has some symptoms of some mild amount of weight loss. I'm not talking about significant weight loss where there will be insulin would be the first choice. What about the modern sulfonylurea? This is a CEPH's consensus statement. Affordable, good adherence, and one of the most important agent for South Asian populations as a combination with the metformin therapy. The modern sulfonylurea has a less chance of hypoglycemia, but you have to educate the patient. Start with a small dose and gradually keep on monitoring and try to reduce the dose of secretagogues later if required. What about the weight? Most of the patients fear the too much weight gain, but with the newer sulfonylurea, weight gain is not that high. And this is the study, glimepiride compared with the DPP-4 inhibitor, and showed a very minimal weight gain with the glimepiride combination therapy. But compared to DPP-4 inhibitor, there is a more robust A1C drop when you start as a first or second line therapy, and therapy failure rate also is slightly less. So ESI RSSDI guidelines 2020 dual therapy, like in these patients, if glucose targets are not achieved, add sulfonylurea, glitazones, SGLT2 inhibitor or DPP1 inhibitor. Individualize the therapy based on the comorbidities. So this patient, we started proactive approach, started secretagogues because of the thinking that patient has a started insulin deficiency. So try to correct the glucotoxicity, so beta cell would improve by giving the drugs. This is a case 3, 50-year-old gentleman, just retired, pre-diabetes for last 2 years, dyslipidemia, smoker for 20 years, started feeling tired and breathless on exertion, NYHA class 2, no polyuria, no polydipsia, no weight loss. Blood pressure well controlled on telmisartan, BMI is 26.8, significantly higher for Indian populations. A1C is 7.2. So he's first time detected. He has dyslipidemia, smoker, and he has a BMI of 26.8, erratic lifestyle, but now he is retired. So what is his target? Though he is 58-year-old, if he can bring down to the 6.5 or below without causing hypoglycemia or weight gain or tolerability issue with the medication, I will still go for A1C target of 6.5 or less. What are our concerns? We are worried about his atherosclerotic risk, which is high because of the smoker, hypertensive, and now is a diabetic. Pre-diabetic also is one of the important risk factor for increased risk of atherosclerotic cardiovascular disease. So which drugs? What are the other investigations? I will like to go for the cardiac evaluations in view of his smoking, hypertensive history, and age of 58 years of age, and pre-diabetic for last 5 to 6 years. So metformin alone as a monotherapy also can bring down the HbA1c under target. But what about the, along with the lifestyle modification, but what about the SGLT2 inhibitor keep ahead of ESC? Metformin has recommendations by ESC because of the high risk for CVD. Now we got a 3 risk factors: smoking, diabetes, obesity, and hypertension. So whether we should be giving SGLT2 inhibitor alone or combination of SGLT2 inhibitor and metformin, I would go for SGLT2 inhibitor and metformin. Metformin is an old friend, comes without any increased cost or tolerability issues. So rather than waiting for one drug to fail, for the potential cardiovascular risk reduction with high risk cardiovascular risk factors in these patients, I would like to give the combination of SGLT2 inhibitor and metformin in this case. Another case, 59-year-old female, 5-year diabetic, normotensive, dyslipidemia on treatment, 4 mg glimepiride, 1 gram metformin, 20 milligram of tenalagliptin. So she is already on 3 drugs combination. Fasting pre-meal blood sugar is very well controlled, but post breakfast is high, post lunch also is high, and post dinner also is high. His A1C is around 7.5, BMI is 28.6. She has a genital mycotic infections in the past with SGLT2 inhibitor, so it has to be stopped. So she has a predominantly postprandial hyperglycemia with a relatively well-controlled fasting and pre-meal sugars. So what are the options? Pioglitazone would increase her weight, though it is one of the good options, or we can add the AGIs because predominantly it is the postprandial hyperglycemia. So in a view of well-controlled pre-meal, we started with 50 mg 3 times a day, acarbose, and sugar came down. Then we decreased the dose of glimepiride subsequently to avoid the risk of hypoglycemia. So this is the insulin sparing actions for Indian diabetic patients specifically, that without producing the hyperinsulinemia, it reduces the blood sugar very well. It reduces the postprandial dyslipidemia, specifically triglyceride inflammatory marker also reduces. Stop NIDD and MERIA studies has shown a cardiovascular benefit with the AGIs compared to Caucasian population. Eastern population has a more robust A1C drop with the drugs like acarbose. Higher the postprandial sugar, more would be the fall, specifically in the Indian setting where the carbohydrate rich meal, like this is demonstrated in the GlucoVIP study, that significant reduction, you can see here almost 70 milligram reduction into the postprandial sugar with the drug like acarbose was seen. So sustained duration of action with this class of action because of the insulin independent mode of action. This is another case, 35-year-old male, type 2 diabetic, 4 years duration, no comorbidities, 100 milligram sitagliptin, 2 gram of metformin. Fasting is 156, postprandial is around 212, A1C is around 7.4, BMI is 24.5. He is busy, business executive with irregular meal timing. So he's worried about the risk of hypoglycemia. At the same time, he's worried about his worsening glycemic control. So what is the target? So again, he's a young, no comorbid condition. My target would be less than 6.5. What are the options? Add the third drug, sulfonylureas, because of the high risk of hypoglycemia because of his irregular meal timing. AGIs, yes, good option, but patient has to take 3 times a day with a busy lifestyle, so slightly difficult. SGLT2 inhibitor, yes, one of the options, and another option is the pioglitazone. So we added an Indian dose of pioglitazone like 7.5 mg. We all have experienced excellent glycemic benefit, excellent beta cell benefit with a small dose of pioglitazone, which is reducing the insulin resistance, no risk of hypoglycemia. We got an excellent first-hand experience of a good beta cell preserving effects of pioglitazones. In between, when pioglitazone was not available in our country, lots of patients whom we had seen 10 years ago who were on pioglitazone were excellently controlled, and they did not require actually the up titration. And we know that it is one of the best agent for the beta cell preservation because of the significant reduction in the insulin resistance. He has a long life expectancy, no cardiovascular risk factor. Glycemia is well controlled both fasting and post meal. HbA1c reduced to 6.8 within 3 months, no significant edema and weight gain. We are worried about the cardiovascular safety of the pioglitazone. We'll just see the 10 years observational follow-up data of the proactive study, which showed after 10 years when the proactive study was over. And this is the forest plot of primary endpoint favoring pioglitazone versus standard of care. See, anything all-cause mortality, non-fatal MI, non-fatal stroke, all-cause mortality, non-fatal MI, non-fatal stroke, cardiac intervention, leg amputations, need of revascularization like bypass or peripheral revascularization. Everything is not increasing, and it is showing a trend towards decrease with the pioglitazone after a prolonged exposure of more than 10 years of pioglitazone. So it boosts our confidence that it is not a cardiovascular unsafe drug, as the meta-analysis with glitazones had shown. So this is again all-cause mortality also showed a absolutely neutral. And this is another study, 13-year study, diabetic patient on insulin without pioglitazone and with pioglitazone. With the pioglitazones and insulins, there was a significant reduction into mortality, but we have to be very careful because the patients will have more weight gain and more edema along with the insulin. So we have to start with a very, very small dose and be careful in a patient with a high risk of congestive heart failure. This is another last patient with type 2 diabetic for last 10 years. Metformin, glimepiride, and teneligliptin, hypertension, dyslipidemia on ramipril, amlodipine, and statin. No history of CV events or heart failure. A1C is 7.8. EGFR has started coming down. EGFR is now 58. Albumin creatine ratio is more than 400. Since last 8 months, he has started gaining weight with some decline in the EGFR and increase into the urinary albumin creatine ratio. So we are worried about his cardio-renal risk. We want prevention of further decline in the renal parameters, EGFR and albuminuria. So one of the best option to start this type of the patient is on SGLT2 inhibitor. All the SGLT2 inhibitors now has shown DEPA, EMPA, and the CANA showed a robust renal specific composite outcome benefit, like 47% relative risk reduction on background of the RAS blockade was seen, and it was irrespective of baseline EGFR. And if you take everything together, EGFR reduction of more than 40%, end-stage renal disease, renal death, cardiovascular death, everything is significantly reduced with the SGLT2 inhibitor. Whether patient had a established ASCVD or patient had a no established ASCVD, patient had heart failure or no heart failure, baseline EGFR, baseline urinary albumin creatine ratio, SGLT2 inhibitor shows a excellent benefit. And now we got a data with a non-diabetic patient also showing renal benefit. So patient with some evidence of renal insufficiency, even though A1C is under target, you should be considering the SGLT2 inhibitor for its renoprotective benefit. Even though the A1C is less than 7%, you can decrease the dose of other agents or switch over from secretagogues to the other agents to have the beneficial effect of the SGLT2 inhibitor. So these patients, for cardiovascular as well as the CKD risk, we gave him the SGLT2 inhibitor for significant improvement into cardiorenal benefit. Thank you very much for your patience hearing. This was some of the cases where the modern and the old oral anti-diabetic agents can be put in our armamentarium, and where and how we should be using this class of the agents with some data to back our decisions. Thank you very much for your patience hearing.
Thank you, thank you. Parag, you did a wonderful thing.
Thank you, sir. Thank you, sir.
6 case scenarios, and every case discuss about the target, the opinion, 1 or 2 or 3 drugs to add, the pros and cons, and how you have managed. And there's a wealth of information, how to initiate, how to escalate, and how to. It's great. And also your initial slides were beautiful. Even though I lost one slide in between, I could see that everywhere you had that curve coming, showing the pros and the cons, and weighing it absolutely balanced manner. Thank you very much. It's not easy to write the entire Ramayana or Mahabharata on the back of a postage stamp, but I should congratulate you and SNN for having given so much of data in such a short time. Dear friends, we have got about 12 minutes, 12 to 15 minutes. So I'll finish in 15 minutes the discussion. I'll take up the questions which have come first. The first question that has come for Dr. Parasha is the fact that, sir, do you find that because of the what effect? Because of the legacy effect and because of the Carolina trial, sulfonylureas have a special situation, special position in our armamentarium? You said that. As the questioner wants to know, do you feel that because of the legacy
Yes.
effect which you showed, because of the Carolina trial, do you think that this drug has a special position in our
Yes, sir.
armamentarium?
Yes, sir. We all were very confident because we all were using the secretagogues for last 4 to 5 decades, and we did not had any apprehension about increasing the cardiovascular risk with the sulfonylureas, modern sulfonylureas specifically.
Yeah.
And with the Carmenilla showing the neutrality comparable to linagliptin, our confidence has increased, and we are not more confidently we are using secretagogues, modern secretagogues more frequently.
Yeah, I think I cannot agree more with you. I call it their contemporary classics compared, like Ramayana Mahabharata, than compared to the newer agents, and they have served their purpose. And in our country, they have a great. The questioner again has liked your two combination you gave. One is Vilda plus metformin, and also metformin plus glimepiride in the case number 1 and 2. And he has. I should say this combination is one of the greatest combination. To Government of India statistics, SNN, the first combination oral hypoglycemic agent is what Parag showed, metformin and glimepiride. And the second combination is after that David's trial, where he showed in the verified trial that you can start as the drug naive patients. You can start with 6.5 HbA1c, as you rightly showed that multiple benefits of the trial. I have a question, the panel discussion. What is your opinion, Parag, about the triple drug combination? And if a triple drug to be chosen, which are the drugs which you believe in the triple drug combination?
Yes, sir. I think all of us are using 3 drugs and 4 drug combinations.
Yeah.
Not necessarily to avoid the insulin, but to take care of the multiple pathophysiological defects. And
Yeah.
now with addressing the comorbid conditions positively with agents like SGLT2 inhibitors. So we have a more robust A1C drop with the triple drug. Second, depending upon the comorbid conditions and age of the patient, we can choose the agents. Metformin, of course, would be the base drug. I think DP4 inhibitor also would go right from the day 1 for almost all of our patients because of the tolerability, cost, and the compliance issues. And depending upon the high risk cardiovascular, third drug would be SGLT2 inhibitor. Very significant hyperglycemia with some polyuria, I would go for the glimepiride or gliclazides. If the patient has a significant insulin resistance, a small dose of pioglitazone also would be a good option. So depending upon the comorbid condition and what you consider is the another important pathophysiology in that particular patient, that is very, very important to decide. Though everything would be contributing, but somebody has lost weight, probably it requires some insulin secretions like secretagogues or insulin. Somebody has asymptomatic with A1C of 9% has more of a insulin resistance, though there will be relative insulin deficiency also. Then you have to see the lifestyle of the patient, whether the patient has a erratic lifestyle or patient has a fixed lifestyle. Then cost also is an important factor. Compliance also is an important factor. Like AGI, I told in one of my patients, AGI is a good option, but patient has a irregular lifestyle, irregular meal timing. It will be very uncomfortable for him to take the 3 meals and 3 pills. So depending upon the lifestyle, socio-economical and the cultural habit, professional, what the job the person is doing, and comorbid condition, I think we have to decide which third drug we have to give.
Excellent answer. It's a customized to all the 7 factors you said, and you have just. I'll come back to you in a minute. I have got very important questions again for SNN. SNN, the questioner wants in the panel discussion, we had put a question. We say that the treatment of hypertension depends upon the comorbid condition. SNN, simply we teach our undergraduates. So if somebody has diabetes, you said one of the natural choice is ARB or SIs, and you said you gave the justification of CCC, the cost, the lack of cough, and most important, the compliance as the taker for the ARBs. And you also said that ARB plus calcium channel blocker is the natural second choice. The questioner wants to know where will you put in diabetes hypertension management drugs like clonidine.
Clonidine is a centrally acting drug. This drug is probably used only for resistant type of hypertension.
Absolutely agree.
Particularly in those patients in whom you have CKD which is ongoing, clonidine will be ideal choice. But now we have moxinidine. Moxinidine is now routinely being used. This drug actually does wonders, and it is not producing the rebound hypertension which we normally get it when we stop clonidine. That is not experienced with moxinidine.
Absolutely correct. The second question in the panel discussion is regarding the gestational hypertension. Like gestational diabetes, gestational hypertension is also a big issue. So I have a very brief answer. We can take up more questions. SNN, just name the drugs you will prefer for the gestational hypertension.
Gestational hypertension is a term which has to be used for patients who develop hypertension beyond 20 weeks of pregnancy, and if hypertension also disappears within 6 weeks after the delivery of this child. So that is considered as a gestational hypertension. And what we normally look at the blood pressure readings. If it is 150/90, you try to treat all women. Whereas if it is more than 140/90, taking that into consideration, you need to start the treatment in a pregnant woman, particularly when the patient has got gestational hypertension. The best drug that is still valid is the alpha-methyl dopa. That needs to be started. There's the only drug which is still valid in a situation where there is pregnancy. Otherwise, in non-pregnant women, we don't use it. In men, we don't use it at all. It is a drug which has proven beyond doubt that it does not cause any sort of problems in the fetus. Even the physical growth is okay. The mental retardation does not occur. And the long-term safety issues have been identified with this drug. So alpha-methyl dopa will be the first choice, number one.
I think also for the pregnancy hypertension itself, alpha-methyl dopa is the drug of natural choice.
Yes. Only thing is, after the delivery, if the blood pressure actually persists and you don't think about gestational hypertension, the drug probably should be stopped immediately after the pregnancy gets over, because it is likely to produce depression.
Yeah.
So that's number one.
Yeah.
Number two is that we should use labetalol. It's an alpha beta blocking drug. 100 milligram morning and night, 3 times a day, every 8 hours or so one can give it. It will produce a good amount of blood pressure reduction along with alpha-methyl dopa. Now the dihydropyridine calcium channel blockers, again another good choice for us to use this particular drug. Particularly the retard preparations will help us to bring down the blood pressure in conjunction with other drugs what I had mentioned.
Thank you. The next question, I have a very brief answer, SNN, is the comparison between chlorthalidone vis-a-vis other diuretics. Chlorthalidone got a new life today for last 2 years. So comparison of chlorthalidone versus other diuretics.
The chlorthalidone actually it has been there for the market for nearly 50 years or so.
Yeah, but
One
you
of the
got new
oldest
life,
drug.
a new
It
life.
has actually re-emerged as one of the best drug because of its one, longer duration of action. Number two, it produces a good amount of reduction in the nocturnal blood pressure rise. It also removes the early morning surge in the blood pressure. Number three. Fourth, it has got a pleiotropic action that has been identified. In fact, no, there is a good comparison which was actually done by using ambulatory blood pressure monitoring, which was presented by none other than Mr. Lee, who is an expert in the field of hypertension. That particular projection had definitely given us an impression that it produces much more reduction of systolic blood pressure, diastolic blood pressure in comparison to hydrochlorothiazide, even with a beta blocker or a calcium channel blocker. I think this particular drug is better when compared to the existing diuretic. Hydrochlorothiazide, it has to be given in larger doses, number one. Short acting, number two. It does not have this pleiotropic mechanism of action, and it produces a lot of blood pressure variability, which is probably not encountered with the chlorthalidone. And chlorthalidone, in conjunction with other drugs in the combination treatment, has actually done wonders, including the sprint trial, which had used chlorthalidone plus azilsartan, which had shown a lot of beneficial effects. And when compared to the other drugs like loop diuretics, which should be used only in patients in whom you have a problem of a chronic kidney disease in association with the diabetes, you used to probably prefer this particular drug only when the eGFR comes down below 50 ml per minute or 40 ml per minute. You need to use only the loop diuretic and not the conventional diuretics. Metrelazone, another all very poor diuretics. Triamterene, again a poor diuretic. Amiloride can be combined with the other diuretic also for the reduction of blood pressure in patients in whom you have more amount of volume overload.
What is your idea regarding the newer calcium channel blockers?
Sir?
And you have to very brief answer, maybe
Sir?
in one minute. Newer calcium channel blockers.
Newer calcium channel blockers. You know, we should know that there are calcium channels. One is a L-type channel, the other one is a T-type channel, the last one is an N-type channel. There are other channels also which we are not bothered. L-type channel, I'll give you an example. One is a nifedipine, number two is amlodipine. Whereas L and T type channel, it is called acylnidipine. L and T type channel. Whereas L, T, and N, benidipine. All three. L and N, benidipine. This cilnidipine. Cilnidipine is L and N. L, T, N, benidipine. Acylnidipine is L and T, whereas only one L, that is for nifedipine as well as for amlodipine. So they block these particular channels. Combining this sort of calcium channel blocking effect in acylnidipine, it reduces the heart rate. It does not produce much of problems, including ankle edema.
Yeah, you gave two drugs for the isolated systolic hypertension and diabetes, ISH, and also showed how it can produce macrovascular complications and also other things. So which one will you prefer between the two for ISH?
ISH is a calcium channel blocker and the diuretic are the best drugs to bring down the blood pressure.
I'll come back to you for the last round. We have got 5 minutes. So I'll come to Parag again. Parag, the question they're asking is that now with the available oral drugs, we can control the diabetes for a very long time, take care of the complications, and also give a long life. What is your most preferred oral hypoglycemics? I mean, they don't want to know the name of the drug, but between the drug. But I think I like the way you put the pioglitazone in the context. You know, I also am a great admirer of pioglitazone, and I have found there are people who gain weight. They weight gain in the beginning and maybe 3 kg, 4 kg, but those who do not weight gain, they do not gain the weight. So I think what's your experience of 7.5 milligram pio? I have found it very excellent.
Yes, sir. Yes, sir.
You agree with that?
Yes, sir. Totally agree, sir.
Good. Now regarding the comparison between the DPP-4 of various types. Now with the advent of vildagliptin, which has become, I use 4 A's: affordable, appropriate, accessible, and easily most affordable. 4 A's: affordable, acceptable, available, and accessible. Both the combinations you showed the first two cases, I like the way you presented. This is the combination most affordable in India. These two combination, metformin plus glimepiride and metformin plus vildagliptin. Now you have a huge practice. I would like to know how do you use? Do you use these two drugs extensively? I use the two drugs extensively. What is your
Yes,
experience?
I also use both the drugs extensively, and sometimes I use 3 drugs also right
Yeah,
from day one,
yeah,
because
exactly.
of the I want, if I'm not sure that Vilda metformin alone will be going to control the sugar well for a short period of time, maybe few months, 2 months to 3-4 months, a small dose of glimepiride or glycosides will take care of the hyperglycemia induced glucotoxicity, will put butacell at rest, and subsequently you can stop the drugs like secretagogues and let the patient be on 2 drug combination like DPP4 and metformin.
Okay, okay. I think great answer. I think I cannot agree more with the answer. The last question to you is that have you found that beyond four, fifth and sixth oral are useful, or in general? I mean, in certain cases we can use, but in general, beyond fourth, you like to change treatment to insulin.
Yes, I think more than 4 drugs.
Yeah, up to four you
I
can use, and
Yes, more
beyond.
than 4 drugs. I think if the HbA1c is slightly elevated, say 7.5 or something, you may think of adding a fifth drug with a different mode of actions. You may think. I don't say that you should add,
Yeah,
but if HbA1c is more than 7.5, because say once the beta cell failure has started occurring,
yeah,
duration of diabetes is there, long-standing hyperglycemia leading to glucotoxicity also. I think the best option after 4 drug fails would be the insulin therapy in 95% of the patients, I would say, unless somebody is in non-compliance with medication or there is a huge challenge with the lifestyle, then there is a different issue. Otherwise, most of the patient would require insulin, not necessary permanently, but few
yeah,
months of
yeah.
insulin
I
will
I
do
I I,
wonder.
I I like that. They temporarily give insulin, then go back again. But I mean, when the toxemia comes down, you talked about glucotoxin, lipotoxin. When it comes down, maybe they will start responding to oral drugs again. Absolutely correct.
Yes, sir. Yes,
Yeah,
sir.
absolutely correct. I will come back to uh, Dr. Narsiman for the last two questions. Is what is your drug of choice for a hypertension in a diabetic with CKD?
Diabetes with the CKD and hypertension.
No,
I think
hypertension, not CKD, diabetes and CKD.
diabetes and CKD. Of course, most of the patients with the CKD also have hypertension. That's
Yes.
the problem.
Yeah.
So we need to control the blood pressure properly. Most of the patients probably may not even respond to the conventional drugs which we normally use for controlling the blood pressure. Drug of choice, again, ACA or ERB should be used as a first drug. Number 2, calcium channel blocker is the best drug to be added on. But only thing you need to wait for the EGFR probably to go up. The EGFR is going down. If it is going down less than 30 milliliter per minute of the surface area, probably one cannot use ACA and ERB. We should probably try to have second opinion before starting this particular drug. Such individuals probably may require only moxanidine or hydrolazine or the labetalol or even the minoxidil can be used. Minoxidil can be used in CKD patients when you don't have any other weapon to use in those situations.
Okay. Okay. I think the last question. I'll take up two questions which are there for the hyperlipidemia. I just wanted to say that the hyperlipidemia treatment has become very simple today. What usually prevents people from treating hyperlipidemia absolutely, what should I say? I think Parag told about aggressive blood glucose control. He said, I will also use 3 drugs when necessary. He also talked about aggressive blood pressure control. And I also feel the question that we have asked in the panel question, that where will you do a aggressive lipid control? I think if there's atherogenic dyslipidemia, if the person has got extreme rise, we got extreme risk, or has got a high risk, there is no other choice than to be aggressive. You agree with that, SNN? We have to treat lipid also aggressively, depending upon the risk analysis and stratification.
Yeah, yes,
The
yes.
second question somebody has asked is to know that what is the correct status after the field trial of the triglyceride lowering drug like fibrate. And he wants, I want only a half a minute answer because I have taken 2 minutes, 3 minutes extra. I have to close now and hand it over to Rita madam. What do you think the status of the fibrate now after the field trial and after the icosapentaenoic acid and the its reduced it trial? It showed that it's very beneficial. How
Actually,
will you? Yeah, very brief
fi-
answer and practical.
fibrates, in fact, no, the field trial has shown some sort of improvement in the cardiovascular risk. People who had undergone this particular trial program has shown only very few beneficial effects. And fibrates, when they are used in multiple trials, like a BIP trial or ACCORD trial or a field trial, if you analyze all the data and go for a meta-analysis of these 5 landmark trials which had used the fibrates, it is clearly seen that about 35% risk reduction can be achieved in those patients in whom you have more than 204 milligrams of triglyceride. And that is the one which is very, very valid, important point out of all this meta-analysis. Only then probably one can think about a fibrate. Now, there is a recently published trial called Accordion, which is a follow-up study of Accord, which has shown legacy effect as you get it in a glucose legacy. The same thing, legacy effect is seen even with the lipid lowering also. People who were recruited for the study have shown benefits after taking fibrate therapy. But it should be reserved only for certain situations and not routinely. Because icosapentaenoic is the best drug which probably need to arrive Indian market soon.
Yeah, it's coming market. I think I cannot agree more. You remember the American guidelines said don't treat triglyceridemia only sub 500 and bring it down to whatever level, make it up. But you see, I strongly believe in Indian patients, hypertriglyceridemia is much more prevalent than hypercholesterolemia. Am I correct? And in Indian patients, we have to treat triglyceridemia. If it comes down with the statins, if it does not come down with the statin, we have to add a fibrate. Of course, we have the wonderful drugs, but wait for it to arrive in the market, like the icosapentaenoic acid and the benefits of the reduced trial. Dear friends, it is not possible to continue beyond this because we are 9 minutes beyond the time. But I really thank profusely the HiGlance Pharmaceuticals, Neeraj, and my dear friend Rita madam, my dear friend Neeraj. Rita madam, thank you very much for giving us this opportunity. And I must tell you that these two are my star speakers. You know, I do many programs, but I love to have these people. API program, I always have SNN. I always have Paraksha. SNN remembers that last time I asked him to speak about lipids and I spoke about hypertension last API in Agra. You remember SNN? So I'm extremely happy and extremely thankful to Dr. Narasimhan and to my dear friend, Dr. Paraksha. I thank you profusely for being with us today and giving a valuable time. And we have been 2 hours and 12 minutes here. And I really thank you profusely. I thank HiGlance for giving this opportunity. But my thanks are due to the numerous people who have logged in, not only in India, but also in Russia, also in the Middle East, East India, East European countries, and various parts of the globe where HiGlance has a presence. I thank them for being here with us, because for you, you're here. If this talks had made any contribution for your practice essential changes, giving you some knowledge, some idea, some direction, then we'll consider our efforts useful. Thank you, HiGlance. Thank you, my excellent speakers. Thank you, Rita.
Thank you very much, sir.
Thank you,
Thank you,
Professor.
sir.
Thank you. And now over to Dr. Neeraj
HiGlance.
Singh. Neeraj, HiGlance. Over to you for concluding. And
Neeraj, thank you.
Thank you, sir. On behalf of HiGlance, I would like to express my gratitude to all of you for your cooperation, which has enabled us to conduct a highly fruitful HiGlance Gold Summit. Thank you all doctors who gave their valuable times and attended the webinar. We are very confident that the health of nation depends on your advocacy. We are thankful for the support you all have given to HiGlance. I would like to express my special gratitude to Dr. A.K. Das from Pondicherry, Dr. Parag from Ahmedabad, and Dr. S.N. Narasimhan from Chennai, who are who have discussed the health issues and their therapeutic option in depth. Thank you, sir, very much. I thanks our management who always encourage such kind of scientific activities. Thanks to our support staff and field force for both division. Once again, thank you to all the delegates who come under one roof for the sake of health and science. Good night, sir, and
Good
happy
night.
weekend.
Good night, everyone.
Good
Thank
night.
you.
Thank
Good
you.
night.
Thank you.
Thank
Thank you very much.
Good night.
Thank you. Thank you. Thank you,
Thank you.
Neeraj. Thank you, SNN. Thank you,
Thank you,
Parag.
sir. Thank you very
Thank you,
much.
sir. Thank you, sir.
Thank you. Thank you. Good night.
Good night, sir.
We tell in French, au revoir. Au revoir means see you again.